I'm Cassie Torok. I'm a assistant professor of pediatrics, rheumatology at Children's Hospital of Pittsburgh. Good morning, and we'll get started with the slides. So what is scleroderma? So scleroderma, the word itself, means hard skin. Sclero, hard, and derma is skin. It's an autoimmune disease, so your immune system is overactive, and it's actually attacking or fighting itself instead of a virus or something that it biologically should be doing. There are two main types, systemic sclerosis and then localized scleroderma. Localized scleroderma is also termed morphia. Those are used interchangeably. Sometimes dermatologists will prefer the word morphia, or rheumatologists will prefer the term localized scleroderma, but those are pretty interchangeable words. So both systemic and localized scleroderma share features that are similar, but then they're also distinct diseases. So we'll kind of go over some of those similarities and differences. And in general, even though they may look different or have different clinical things going on with them, when you actually look down to some of the research that has been done, or looking at the skin and looking at the biopsies, they actually look pretty similar. And some of the markers that I'm seeing from a research basis are actually very similar in pediatrics between the localized and systemic, as well as the adult systemic too. One misconception is, oh, my child has morphia or localized scleroderma, is that going to turn into systemic sclerosis? The answer is really no, unless they're that like 0.001%. So it does happen once in a very, very, very blue moon, but that's not something that we discuss with our patients as far as predicting that to happen. Usually they're kind of one or the other. Autoimmune disease, I mentioned that scleroderma is an autoimmune disease. So in general, the immune system, as you guys know, is supposed to protect us from germs and bacteria and viruses. It's designed to trigger an inflammatory response to get rid of those viruses and bacteria. But unfortunately, in autoimmune diseases, the immune system gets turned on, but then it kind of stays on instead of going back to neutral. So with this being on, it gets confused and it starts attacking the skin and the fat underneath the skin and sometimes the blood vessels and things. And that's just an ongoing response, and that's why we do need our medications that kind of help the immune system kind of go back to neutral instead of kind of staying on this overly active state. So scleroderma is an autoimmune disease that has this inflammatory component that we were talking about, but it also has an additional component. It also has what we call fibrosis, or thickening of the collagen. So the skin's made of different proteins and different substances, and one of them is called collagen, and the inflammation that keeps going on triggers some things to make the collagen kind of build up over time, and that's why it feels thicker. And then also the extra autoimmune component in scleroderma is also either causes inflammation around or in the blood vessels as well. So how do we link the two? In University of Pittsburgh, we have a newsletter that we give to our patients called The Collagen Connection, because that connects the two things. The localized and systemic both have the overproduction of collagen, the thickened skin, things of that nature. And when the dermatopathologist looks at it under the microscope, they really look the same. Like if you say, you give them a biopsy of the skin and they look under the microscope, the pathologist couldn't say this is localized versus systemic. They can't tell the difference. The inflammation and the collagen look very similar. I'm just looking for the little PowerPoint. There we go. We'll do this. So this is kind of early changes. That's that inflammatory part that I said the immune system's overactive, causing all these extra immune cells that are kind of these purple dots that you see. And they're actually around a vessel. This is what I'm pointing out. They're kind of focused around vessels, okay? And then this is later, after that collagen gets deposited, after that inflammation is going on, causing the thickening and layering of the collagen. That's what it looks like kind of later. And this is in pediatric scleroderma, focusing a little more on localized on the one side and systemic on the other. Because actually I was at the poster last night and people asked, hey, is scleroderma kind of more frequent now in children? And I think the answer is no compared to years ago. I think it's just recognized more. But there is a difference between localized and systemic in children. Localized is much more common, 8 to 10 times more common in pediatrics than the systemic form, whereas it's the flip for the adults. In the adult scleroderma, systemic sclerosis is 10 times more common than localized. So in kids, The localized scleroderma, or also termed morphea, is more common. And usually it's unilateral, meaning one side. So usually like a line down the arm, down the face, down the leg, but not uncommonly, though, it can be both sides, or the left side on the arm and a right side on the leg. That's not unusual as well, but the more common pattern is the one side. And then extracutaneous or non-skin manifestations do happen in localized scleroderma. That was another question that was brought up at the poster last night. Someone was asking me about that, and it's quite common. Usually this is going to be the joints, the bone, the muscle, kind of underlying that linear band. So the joint might be stiff, it might have arthritis. That arm, if it was down an arm, might be smaller in girth or smaller in length. Things of that nature are not uncommon in the localized scleroderma. And then also, if the child has head involvement, sometimes there are neurological or brain changes or eye changes or dental changes or jaw changes as well. Internal organs such as lung, kidney, and heart are very, very, very uncommon in the localized form. So that is different from the systemic. So the systemic scleroderma in kids, there are parts that are obviously similar to the adult systemic. They have the skin involvement with the thickened skin starting usually from the hands and toes kind of going centrally, and it's usually a little more widespread. When this word circumferential involvement, that means like around the whole arm or the whole limb. So it's usually not just a line or a band, it's usually the whole arm that might be thick. And then Raynaud's phenomenon is extremely common in systemic sclerosis in kids, just like adults, upper 90%. That's when you get the color change, the red, the blue, and the white when the kids get cold or there's stress or things like that. They'll change the color of the fingers. And extracutaneous manifestation, meaning non-skin, is more common in the systemic scleroderma kiddos. Some joint and muscle, as we kind of already mentioned, but then they're the ones that also have the extra heart, lung, kidney, gastrointestinal involvement as well. So this is just one of my patients to give you guys an example of the localized scleroderma. This is her when she was very young. I think she was 5. But this is, but to show you that she's living her life, she's climbing up a tree, she's having fun, but she's learned to kind of adapt with this change. You can see that she has that classic linear band down her arm, and then her fingers actually contracted underneath on her 5th digit, and it's going down her 4th digit, and her 4th digit is actually smaller than the other hand 4th digit. This is her years later, and this actually not just the one side, but did affect the other side as well, and you can see her thumb's smaller than that thumb. And then there's kind of that linear band, and then a change. She has some what we call ulnar deviation of her wrist, so there's some almost arthritis-like changes there too. Okay, and this is that finger that's tacked down. This is one of my patients with systemic scleroderma. You can see that she has a little bit more of that tight lip, or kind of sometimes they say mouse facies. So sometimes you get thickening around the mouth, and you get the thinner lip, and the gums are receded a little bit. So she has a little bit more of the systemic scleroderma kind of face. She has a little bit thin skin. It's hard to see, but a lot of times they'll have thinner skin. You can see the neck veins sometimes more easily. And then also she has what we call sclerodactyly, or the kind of swelling of the fingers that goes with the Raynaud's and things, and the skin changes. And then she has some digital pitting ulcers from the ongoing Raynaud's, so you can see these little ulcers at the tip of her fingers. So just looking at those, they look different, right? But these are 2 kids with the 2 different forms, just to give you an example of what a child would look like with these conditions. So who gets this? This was actually another question at my poster last night. Some people were wondering, hey, is this more common in girls than boys, etc.? Like, what's the ratio? So it is more common, both localized and systemic in pediatrics, for females more than males, but it's not that big of a ratio. It's like 2.3 to 3 females per 1 male, which is not, it's more skewed towards female, but not highly skewed towards female. So there's not a very strong estrogen component that we know of as of right now, whereas diseases such as lupus, it's kind of like a 9 or 10 to 1 female to male. Even adult systemic sclerosis, it's a little more kind of like 7 or to 9 or so female to male. So this is a little bit different in juvenile, that females are more affected, but not so much more than boys. Another question was, well, when's the mean age of onset? So it's 7 to 9 years old, both for localized and systemic pediatric onset. And both show up once in a blue while in kind of the infantile stage, but that's very, very, very rare. In some bigger registries, it's like 0.5% or something like that. Most of my patients, I could say, fall in this 7 to 9 year old onset, but there are kids that are younger. And then as far as is their racial kind of predilection, so the juvenile localized scleroderma, we've seen more common in Caucasians in cohorts in Canada, the US, in Europe, and then, we don't know the exact incidence, but they are seeing it more. So one of my colleagues has a morphia in childhood, adult and childhood cohort, the MAC cohort down in Texas, where there is more other racial diversity, and they're still seeing it basically almost 90% in Caucasian. So there is that propensity there. But in juvenile systemic, there has been no racial predominance that we have seen. Diagnosis in general is delayed. It's just kind of a chronic smoldering condition where I'm sure a lot of you, if you have children with this, that you may have gone to a couple different doctors till people figured it out. That's not uncommon just because it's a uncommon condition, and some people it's hard to recognize right away. So it's not uncommon to have about a year or so delay, 1 to 2 years in diagnosis from the onset of the symptoms. So how's it diagnosed? It's really the history. So we'll talk about labs in a little bit, and labs are helpful and supportive, but it's really getting the clinical features, some that I kind of demonstrated on some of the patients already, and just the history, the pattern of problems that kind of fall into place. And this is true for any autoimmune disease such as lupus, et cetera. Kind of we need that history and physical exam to kind of put together. And the lab and the imaging studies are supportive. There's not a genetic test or a single test that really helps you diagnose it. So skin features that we look for on exam to help us diagnose would be the harder skin, so the increase in skin thickness as we saw the collagen deposition on the prior slides. And there's that sclerodactyly that I mentioned, that thickened skin over the fingers, making it kind of hard to kind of bend and get a full grasp. And then you lose some of the mobility, and that's more common than systemic when it's widespread, every single finger. In localized, you saw that one patient, that can happen in individual digits that are affected by a linear band. Color changes, this is a little more in the localized scleroderma that we see this, and it's very helpful for us if we see kind of like this violaceous rim or lilac rim around like a shiny yellow waxy white lesion. That makes us think, oh, this is active disease, let's get on it, let's treat it. But there are times where it looks kind of more purple or bruise-like, so sometimes it will kind of be thought of as this bruise. It won't go away at first. And then there's some other changes that happen later after the inflammation goes away. Sometimes you're left with what we call post-inflammatory hyper or hypopigmentation, so too much or too less pigmentation after that happens. And that can happen both in localized and systemic. So here's a systemic scleroderma patient with that poofy hands, that sclerodactyly look, and she's African American and with darker skin. You can see that she has that hypopigmentation around her knuckles and around her fingers. Here's a Caucasian patient with linear scleroderma down her arm, and she has that post-inflammatory hyperpigmentation. The names, these are physicians that contributed these photographs. So other skin features that gives us clues that this is localized or systemic scleroderma are thinning of the skin, which is called atrophy. So the dermis, that top layer of the skin, or the subcutaneous or the fat layer right underneath the skin can be thinned out and kind of look like a little, sunken plateau. And that can show the veins, we call that visible veins. You can kind of feel structures underneath. So here from my colleague Dr. Lee is a picture of a patient with localized scleroderma. You can see the veins are more visible. If you were to look at this patient, it looks a little bit more like my patient here. We can almost see like this cliff drop, like the skin is okay here and that just stops and cliffs out. And then you can see all these visible veins and things. So that's the thinning of the skin. Some other classic changes that would be seen more with systemic sclerosis are dilation of the blood vessels and kind of turning that little like spider web kind of look. So these are telangiectasias on this patient with the systemic scleroderma. We see that sometimes in the localized, but more like in the damage phase, like after some activity, you'll see little telangiectasias sometimes within the lesions. And then here's just more of that atrophy. So you can see the subcutaneous or the fat is really gone in a lot of this patient's leg with linear scleroderma compared to their unaffected leg. Calcinosis cutis is just a fancy word for calcium deposits in the skin. And in systemic scleroderma, they form in pressure points, so usually top of the knuckles, elbows, sometimes knees, things like that. In this patient of mine, it's kind of in the middle of her finger. Here's her underneath her finger, so obviously that makes things problematic for function and can be painful at times. And then ulceration is another finding if the clinician is trying to figure out is this scleroderma or not. These are some of the, I showed you some digital ulcers already, but these are kind of digital tip ulcers that have healed and kind of given this like thickened skin to the tips of this young lady's fingers. This is a young man with systemic scleroderma that I treat, and he had quite significant Raynaud's. You can see his fingers are kind of like purple, and then he has these digital ulcers that are starting to form as well. So those are clues to say, hey, this is a scleroderma. So then a little bit about disease subtypes, because I think that can be confusing as well. Sorry, the slides started advancing. Especially when you hear all these words and terminologies, like what does that really mean? So localized scleroderma, again, I mentioned morphia is also a word that's used for that, and that's okay. So the subtypes of the localized scleroderma, or also termed morphia, there's a couple. The most common that we see in children is linear. So that's that linear band I mentioned, usually affecting an extremity, so an arm or a leg, but at times the head as well. So when it's affecting the leg or the trunk or the arm, we call that linear of the extremity or the trunk. And that, as I mentioned, is usually unilateral or one side, but as you saw in the patient I already showed you, she had it at first down the one arm, but then it went down the other. So it's not too uncommon sometimes for it to be bilateral or both sides. When the patient has the linear on their head, it can be called two different things, but it's still kind of in the same realm. So if you have a line down the forehead, a lot of the times people will call that une coupe de sabre, or sword of the saber in French, just meaning like it looks like a linear depression. And you can get hair loss, as you see with this young boy. This is a picture from the American College of Rheumatology, has hair loss and then kind of this linear band, but then he also has this half of his face is smaller. That's what we call Perry-Romberg syndrome. So you can have two things together. I have patients that have une coupe de sabre, or a line on the right, and then on the left they'll have the Perry-Romberg. So it can be interchanged. So I just want to make that clear that some people have more of one than the other, but in general they're very similar and they overlap several times. And then you can even have a mix. So you can have a linear band on your arm, but then also a linear band on your face. That I've seen, maybe in, 10-15% of my patients, so that's not uncommon either. So these are also pictures of circumscribed or plaque. It's another kind of localized scleroderma or morphia. Superficial means it's kind of more on the surface. So this is a patient of Dr. Lee's. You can see this kind of circular white waxy plaques on her neck. And then this is one of my patients. This is what we call a deep circumscribed. Circumscribed just means it's a semi-well formed, so it looks like it's kind of a scoop out of her hip area. This is a patient going back to the facial involvement with more classic, what we call Perry-Romberg, half of the face smaller without a linear line, going down. And this is another type we call generalized morphia or generalized plaque morphia. It's just multiple of those plaque morphias throughout the body, trunk and extremities. And I just wanted to give you an example of a Caucasian patient and what it might look like. So here's some hyperpigmentation. We talked about that brown pigment, but then she also has active disease. It's kind of like pink all throughout, and she was having some new lesions. And this is an African-American patient to give you an idea of someone with darker skin. Her unaffected skin is actually this in the middle. So all of this change is actually that generalized plaque morphia everywhere, and then she has like thick kind of patches within it. And here on her arm, you can see that she has some unaffected skin, but then her affected skin is here. So it's kind of more diffuse and everywhere. This is not super common in kids, maybe 10%. In adults, it's a little more common. It's around 30% or so. Pansclerotic is very uncommon, but this is when basically almost all of the extremities, both sides, are involved and very tacked down and atrophic, meaning, remember, that's like the skin and the fat is gone. So you can see this young man, he really does not have any fat left in his arms or his legs, and he has a lot of what we call joint contractures, so limitation range of motion of several, small and large. I wrote rare. I would say less than 5% for sure of all of our cohorts have patients with the pansclerotic morphia. Those patients, since it's like goes all the way around their skin, they're more prone to have ulceration, especially their legs or their ankles, just because it's so tight. It's hard for the circulation to kind of maintain healthy skin. And sometimes with these recurrent ulcerations, there is a risk of skin cancers as well too. But again, this is the rare subtype. It's not uncommon for kids to have mixed. The most common mixed is kind of what I mentioned, some part of linear, whether it's like the linear of the extremity, and then maybe plaque morphia, or I have several with generalized plaque morphia and the linear as well. So then those are the localized scleroderma or morphia, and hopefully that was helpful to see pictures, because that's a common issue, is just the terminology of things. So now we're switching gears to as the disease subtypes within systemic sclerosis. So these fall along the lines of what the adults use. They kind of call them diffuse cutaneous, limited cutaneous, or overlap. So diffuse cutaneous just means that it's affecting a lot of the skin, most of the skin. And it has to go, so this is a picture of the skin affected in diffuse, these little gray shadows. So it really has to go beyond the knees and beyond the elbows. So if you see limited, see how that skin, if it's thick, it can go from the fingers to the elbows, but it stops. And it can go from the toes to the knees, and it stops. And they don't have it here, but in limited, you're allowed to have thickness of your face as well. But once you start getting thickness of like your arm, your thigh, your belly, your back, then that kicks you over to diffuse cutaneous. As far as the subtyping and what's the difference? Why do we use these words? We kind of classify them because they are associated with different organ manifestations. So the diffuse cutaneous will have the internal organ involvement if they have it. Typically, not all the time, but typically is that first 2 years that those organ involvements kick up, like the scleroderma renal crisis, some cardiac and lung issues. There's more interstitial lung disease in the diffuse cutaneous. Whereas the limited, the skin thickness is kind of a little bit slower, and they usually have long-standing Raynaud's. They have sometimes more GI involvement, so more gut problems, and they have more of those telangiectasias that I showed you the picture of, and they have internal organ involvement. Typically it's later, it doesn't have to be, but typically it's a little later down the timeline, like years later, and they have a little more pulmonary arterial hypertension than the diffuse do. So that's why we even bother with divvying up why the skin is affected in different places, because it helps us educate the patients and ourselves. Okay, let's screen for this. This might be more common in this subtype. Do you want to do questions now or at the end? Okay, we can do a question.
Okay. When you say later internal organ, later as in while you're still treating them as a pediatric patient, or later as in adulthood you start seeing major changes that affect organs?
Later is typically years later. So diffuse, it's usually the first 2 years where you'll see a lot of these organ manifestations come up. And in the limited, it's kind of after those 2 years. So it can be anywhere beyond 2 years. Correct. Yeah. No, no problem. No problem. And then overlap we see more common in children. So this is around 30% in kids, where in adult it's maybe 10% or less. So what we see is the skin changes, but then we also see arthritis and myositis, so inflammation of the joints like rheumatoid arthritis, and then also inflammation of the muscles, so make the kids are weak and things of that nature, and some certain skin findings that go along with that. So that is a little more unique in kids. We do see more of that overlap. So my typical patient that will come with systemic sclerosis that is in this overlap category will have the Raynaud's, the poofy fingers, some muscle weakness, and some arthritis. So those kind of combination of those clinical features make me think this patient will probably fit into this overlap category. And here's a picture of that classic kind of sclerodactyly that we kind of talked about, the poofy fingers, one of my patients. So this is a little bit about how you guys are asking about maybe prognosis or kind of like looking forward, what our difference is. So this is a little bit different from adult because I've been referring back to adult. So going back again to localized and systemic, so we're talking about both things now. I'm going to do systemic first because we were just talking about that. So we were talking about the subtype pattern is similar, but there's more overlap that I just mentioned. That limited is a little less common. So you saw in the adults the limited maybe 30, 40%. In kids, that's more like 5 to 15% in some cohorts. Some cohorts they see up to 30, but most it's around like 15%. Prognosis in kids in general compared to adult systemic scleroderma is better. Usually there's less there's less internal organ involvement. They have way less scleroderma renal crisis, less lung disease. It still happens, obviously, but way less pulmonary arterial hypertension, and interstitial lung disease, as well as cardiac and esophageal. So the frequency is less, which is good. It still happens, but frequency is less. More musculoskeletal, as I mentioned, because they have more of that overlap. So kids with scleroderma, systemic sclerosis, have more arthritis and more myositis than adults. So that's what's different a little bit. Juvenile localized scleroderma compared to adults. So in kids, that linear is more common and the mixed is more common, where adults, that circumscribed or like a single plaque lesion or that deep, like scooped out plaque lesion, that's more common in adults. And then the prognosis in kids is usually a little worse than adults just because this is onset in their kids. And remember, I said like 7 to 9 years old at onset. So that's when their bones are growing, their muscles are growing. So if it's a linear band down their arm, in the end, they might have a shorter arm or a smaller, finger, as you saw in some of my patients, et cetera, or in their leg. They might have some leg length discrepancy and then some trouble walking or back pain because the leg is, a centimeter, an inch or so shorter than the unaffected side. So that's where that does impact kids more because the adults, if you had a linear band, your arm's already grown. So yes, there's some discoloration and hardening and maybe the joint issues, but there's usually not that growth issues. And also if it's affecting the head and the child is young, their jaw is growing and things, so there can be some significant dental and orthodontic kind of issues going on as well. I'll do questions at the end just because they're recording this, so just to get the information out. And then the deep tissue involvement is, again, more in children because they're growing and that it can kind of make the muscle smaller and things of that nature. When the last longer, I would say it's just the inflammatory active state. This is older literature, was kind of like longer in children. I think in general, though, it's just recognized more that the active state of localized scleroderma doesn't just fizzle out after those like 2 to 5 years that was initially quoted. So I would say that's not too different than kids for adult. And the last point was what I was mentioning, the growth and development can be affected in kids. So lab testing, so remember we're talking about like evaluation and things of a patient figuring out localized or systemic. In juvenile systemic scleroderma, that ANA or that autoantibody, that is more common, close to 97% in some of the cohorts they looked at. The other antibodies you guys will hear for systemic scleroderma would be SCL70 or topoisomerase. That's in a fair amount of kids, 20 to 40%, but less than adult. And the anti-centromere, that's the 5 to 15%. That goes along with the limited subtype, and this topoisomerase goes along with the diffuse cutaneous. And then there's other antibodies. I don't think we need to go into detail, but just to show one of these specific one, RNA polymerase 3, is very infrequent in kids. It's 2 to 8%, where in adults it's more 15, 20%. This is the one that's associated with scleroderma renal crisis, and scleroderma renal crisis is very rare in kids, and the antibody is very rare in kids. So just showing the antibodies do sometimes reflect and help us judge clinically what may or may not happen to these children. And then that overlap that I talked about, that's like 30% of the kids with systemic scleroderma. several of them will have this PMSCL, that means polymyositis/scleroderma, so a myositis and scleroderma mixed together antibody, or U1-RMP. The name's not important, but just to say, like, your clinician will probably check for these antibodies to see if then you fit into this clinical kind of subtype to then help with predicting organ manifestations, things of that nature. So blood work, that when the doctor takes your blood work and they're trying to figure out if you have systemic or localized or a connective tissue disease, usually the labs actually aren't that dramatically abnormal in scleroderma patients, whether it's localized or systemic. Systemic has a smidge more anemia, maybe the muscle enzymes are elevated more, and a SED rate, which is a general inflammatory marker, and sometimes CRP is another inflammatory marker, or kidney abnormalities. But actually, usually it's not like some of our other diseases such as lupus and some forms of juvenile arthritis that have a robust inflammatory response in the blood work, and it's easy to find. So that's why, some of my research is really honed in on finding a blood marker that is helpful, because our standard ones, they're usually pretty normal. Only a low percentage of patients have some abnormalities in the routine blood work that we order as clinicians. In localized scleroderma, it's similar, where you have some of these autoantibodies, that ANA, that anti-nuclear antibody that I just showed a little picture over here, just how the lab will do it, but that's present but less common than systemic, where I mentioned systemic can be up to 97%. In localized, it's around half or 50%. Other antibodies that we do check in localized scleroderma is this antibody called histone, or single-stranded antibody. Sometimes we'll get it in the beginning just to say, hey, is this going along with their disease? It'll maybe help kind of clench a diagnosis if there's some little piece that's missing. I, on a research standpoint, am kind of looking at over time to see, is it going to help as far as predicting disease activity or not. So we're still looking into that, but that's one of the antibodies we might check for. And as mentioned, in localized, similar to systemic, where there's not that many routine labs that will be abnormal, but once in a while you'll have elevated inflammatory markers like that SED rate or CRP, and sometimes some muscle enzyme elevation if they have like a deep linear lesion down their leg and they have some muscle involvement. Sorry, I'm trying to just get the mouse to appear. It's going the wrong way. Okay. Sorry, guys. Okay, there it is. All right, and then skin biopsies. So I think they're very helpful, especially if their diagnosis is unclear and the dermatologist is kind of like, oh, it could be X, Y, or Z. It is helpful. And sometimes if you're not sure if the patient is having a flare, sometimes that is also helpful to see if there's inflammation that's coming back as well. So other imaging that can be helpful to the clinician, again, it's not like a slam dunk. It's not like this MRI will tell us exactly what the diagnosis is, but putting the clinical picture with the imaging is helpful. So sometimes ultrasound is helpful of the skin and the fat underneath the skin and the joints. Dr. First had a ultrasound poster last night, adult scleroderma, but looking and seeing the tendons and joint tissue that's involved with systemic scleroderma, so that was kind of interesting. We do that as well sometimes. MRI, so looking at the joints and internal organs. Again, systemic versus localized, they're going to be a little different. X-rays and CTs, sometimes for systemic scleroderma, you need a CT of the lungs, etc. And thermography sometimes is used at certain centers to see the temperature of the skin to see if they have active disease in localized scleroderma. And then other studies that are more organ-specific, again, more with the systemic scleroderma, would be pulmonary function test for the lungs, heart, like an EKG and echocardiogram, and for the GI to do barium swallow or endoscopy like a scope for systemic scleroderma, and a slit lamp exam to look for uveitis or inflammation. That can be actually in localized scleroderma if they have head involvement especially, or systemic once in a while does have those changes, but systemic has more of the dry eye changes. So this is just a picture from Dr. Lee in Hackensack, New Jersey. I collaborate closely with her. This is just interesting. A patient that has linear scleroderma on their finger. Their patient was saying, I'm starting to have some pain again, but Dr. Lee's like, well, I don't see red, I don't see the violaceous, I don't see waxiness. She didn't see any objective signs of disease activity, but she said, let's see if my ultrasound machine will help see if there is inflammation. So here's the other fifth finger on the unaffected side, so you see that that looks okay. And this is the affected side, the fifth finger you're looking at. And this is power Doppler, so this is looking at the blood flow. So there's increased blood flow there. So it's like, oh, That's different from the unaffected. So that looks like there is some subtle activity going on. And then she treated with medications and re-imaged afterwards, and this was the unaffected, which again looks fine, no real Doppler signal. And then the Doppler signal in the one that was affected went away after treatment. So ultrasound can be helpful when you're kind of figuring out if the disease is active or not. It's not at every center. It is expensive and it takes trained ultrasonographers to do it, but it's an option. MRI as well. These are just kind of supportive things for you guys to take a look. But this is looking at a patient's affected thigh or leg. That's unaffected. And this is like a chop, like, coming right down here, like on the thigh. And you can see this is the outer layer, like the skin and the fat is here. And then this is actually called the fascia. So it's like a layer in between the fat and the muscle. And that's really on fire, like it's white. You can see over here it's not really white. So this is some inflammation that can be kind of subtle because it's not right on the skin, right? So the MRI can be helpful if you're kind of like, oh, is my daughter having a flare or not? You're working with the clinician and they don't see the obvious skin changes I talked about. Sometimes MRI is helpful for deeper involvement. This is specifically for linear scleroderma. So it's just like a little blip into the imaging. In the essence, I'm looking at time is going by, so I'll kind of move a little bit. So, for parents, you have a patient, a child, and they just got diagnosed with, the linear scleroderma or localized scleroderma. So what can you expect? What should you be concerned of or look for? So I mentioned that of the non-skin or extracutaneous skin manifestation, musculoskeletal is one of the most common. So they can have joint pain. So they might not have arthritis, but they have joint pain. That's called arthralgia. They can have joint limitation or contractures. This is extreme from a patient I presume was non-treated on the ACR, but they can have, decreased range of motion of their digits and have some function issues with daily activities. And that can be from deeper involvement of the fibrosis of the skin and the tendons. And then they can have arthritis. It's not that common to have straight up arthritis, like a big swollen, warm knee that's warm, like a typical juvenile arthritis. So that is uncommon. It's more of kind of like that joint pain and the limitation that's more common in the localized scleroderma. A fair amount will have some muscle pain, and then as you guys saw that you can have muscle atrophy or loss, like such as this patient. Her girth of her leg is different because the fat is less, but her muscle is also less here. And then she also has like a 1.5 inch limb length discrepancy, so she has an abnormal gait, and she does get pain, like in her hips and her back and things of that nature. Other growth problems would be undergrowth of, we talked about the muscles and joints, but also head lesions. This is one of my patients. Unfortunately, she was untreated for a while, and she has underdevelopment of the fat and some of the skeleton of her side of her face, and has some dental abnormalities too. So this is something that can happen. The arms we talked about being thinner or shorter. Here's another example of a patient, and this is from like the ACR. So this is a non-treated patient a long time ago, but they're definitely missing muscle and things of that nature. So kind of looking at some prospective studies that we've done, about a quarter will have like lower bone size as well in the affected bone, the infected side, like you can kind of see that. And then almost half have a smaller girth and or some bone changes. So the growth may not be obvious until later. That's just to mention if you have a child and they've had stable linear scleroderma on their face or their leg, but then they're going to puberty. It's not, the disease usually doesn't flare in puberty, but sometimes it's more obvious because they'll get a thinner face. They lose their baby fat, and they don't have like the kid round face anymore. So it'll be like, oh man, is that sunken in? Usually it's not. Usually it's just the face maturing or the body maturing, especially if they have a trunk lesion and they're a guy and they're doing football and they're getting abs. It looks deeper, but it's just they're getting more developed in their muscles and things and losing some of that baby fat. So other problems with localized scleroderma that sometimes we encounter, peripheral neuropathy. So if you have a linear down your hand or your arm, almost like a carpal tunnel that you can get from nerve pain and things from the nerves being trapped if you have that thickened down skin and tendons, etc. And lesions on your head or scalp, we kind of mentioned the hair loss, sometimes eyebrow or eyelash loss, oral or teeth problems. So you can see this Patient of mine has a lot of malalignment there, and his teeth, he has some abnormal teeth that they'll need to pull some baby teeth, etc. And then also tongue hemiatrophy can be smaller on one side, but that usually doesn't affect function. Usually the muscle of the tongue is fine. Brain involvement, there are patients that have seizures or headaches or vasculitis or inflammation of the blood vessels. This is one of my patients. The lesions on her right side, and then on the right side of her brain, she has these white matter changes that are directly in line with the lesion on her skin. She actually doesn't have symptoms, but this is where so the lesions may or may not have symptoms, but it's something you need to look for and then monitor as well. Eye problems, uveitis, I mentioned that slit lamp exam for inflammation, dry eyes, sometimes some vision changes. And again, these are patients more with the head involvement that I'm mentioning. Oh, this one didn't pop up, but there's a cute little girl I follow in her. She has dental involvement. She has a linear band. I didn't show the front picture, but you can't actually see any changes. It's not until you lift her lip up that you see this linear band from the scleroderma going down, and then her root of her tooth is atrophic, so that tooth may or may not stick around. Sometimes they do need prosthetic teeth and things. But usually with early dental intervention, they do well. So it's a chronic disease. It's true for most diseases. It's variable. Some are mild and remitting and relapsing, but some are very active. Treatment is individualized. And in general, our goal as clinicians is just minimize the disease impact. So get that inflammation under control right away as soon as we can. And that's why I mentioned some other modalities like ultrasound, MRI. If you're unsure if there's activity, we do sometimes push for those things to see. And that's why I'm working on biomarkers to help us see if there's issues and you can't 100% tell if the disease is active or not. Manage symptoms to get the function improved, a lot of PT, occupational therapy, physical therapy. Our growth, we're aiming to kind of help support normal growth and development. Like I said, dental involvement, get that treated right away so that you don't have longer term changes. So this goes back again to get that inflammation controlled. And then do extra additional things like for hard skin, some emollients, protections against the elements. The PT and OT is really important. I can't stress that more. I've kind of talked about that in some of my talks before. Just kind of helping move those joints around. There's a whole pharmaceutical talk tomorrow by Joanna Harper, so I'll leave the ins and outs of the medicines for her. But just in general for localized scleroderma, and then I'll do a slide or two just for systemic. The medicines are similar actually between the two, but our first line is still methotrexate, injectable or pill. Corticosteroids is active disease, IV or oral, like prednisone, and then additional disease-modifying antirheumatic agents like Cellcept, Plaquenil, sometimes imitinab or Imuran. These are other things that have been used. We're also, if the patient does the routine steroids and methotrexate and or Cellcept, and they're still not doing well or they have a flare through that, that's when we usually entertain the biologics, such as Orencia or Actemra or Remicade. So, and rarely will we go to kind of a little bit more of the stronger medicines, such as the IV Cytoxan and things. Now this is for localized scleroderma. Sorry, this slide got a little, the other treatments are NSAIDs, obviously for joint pain, some Motrin, things of that nature, but they're not going to control the immune system, they're just going to help with the joint pain, etc. Some phototherapy is helpful for certain types of skin lesions in localized scleroderma. We work with dermatology if we feel that would be a good route to go. And then surgery is helpful for this patient such as this. He has the Perry-Romberg, and he had fat grafting in his face. This is before, and this is after. You can see it kind of evened out a little bit. So we'll do that when we feel the disease is quiet, and we feel it's fine to do the fat grafting. So systemic scleroderma, this is a little bit different. Obviously, they can have lung, heart, kidney involvement, etc. We're running low on time, so I'll just kind of show pictures. We've kind of touched base briefly on these things. The skin changes are, these are just some more examples of what I mentioned before, the sclerodactyly, the telangiectasias, but I wanted to show you that these are sometimes subtle, like in this girl, my patient, it's subtle. It's some of the adults, it's very robust and it's easier to make the diagnosis, but just, they really have to look. So this young man of mine, he had the purple fingers on the one side. He has the telangiectasias on his lips. And then here's the sclerodactyly. And that's why I just wanted to mention it's more subtle sometimes in kids. Here's Raynaud's phenomenon in kids. This is the more classic Raynaud's changes. This is another Raynaud's of the feet of a pediatric patient. And then here's some of those digital ulcers and kind of purple changes. In darker skin or African American, sometimes it's hard to see that purple, so really pay attention. This is purple and discolored fingers and ulcers. Here's one of my patients with a bad ulcer, a bad flare. And this is those nail fold changes. If you've heard people talk about the vessels being changed, that's what we're looking for. This is an obvious one, but then we have to look sometimes with a microscope and look. So these are just some pictures of things that can happen with the vascular or blood vessels. So Raynaud's is very common in kids with systemic scleroderma, so 90%. And then the nail fold capillary changes like that is 70%. And then digital ulcers, in a recent survey of a international cohort led by one of my European collaborators and the CARA cohort, the Childhood Arthritis and Rheumatology Research Alliance here in the US and Canada, we've seen about 50% of the kids with systemic have digital ulcers. So it is higher than was prior reported, because I think it was underreported in the literature before. But remember how I talked about that pulmonary arterial hypertension is less common in kids? It's around 2 to 13% in these larger cohorts that we've looked at. Other lung problems in systemic scleroderma and other screening things that we should do is, it's, as I mentioned, it's less common that pulmonary arterial hypertension, but we screen with echocardiograms, look for that left heart pressure, pulmonary function tests where they breathe through the tube. I have a picture in a second. They're looking for the gas exchange across the lung and the blood vessels there. Interstitial lung disease, that's the picture of this. This is an adult actually, but this is like the fluffy changes. And this is a CT scan. This is the chest. This is the back. Here's your heart, but these should not be here. It shouldn't be this kind of patchy, glassy looking change and then these like open airspace bubbles. It shouldn't look like that. It should just kind of look a little bit more kind of clear. So in kids, 10 to 25% get interstitial lung disease, which is less than adults, but it still happens to a fair amount of kids. So we screen with chest x-ray, pulmonary function tests. We look for the gas exchange and the volumes, and then also the CT scan, which is those patterns I mentioned. This is a child doing a pulmonary function test, so you can actually see what it looks like. This is a diagram, so you can see the pressures and things, how they measure, but this is an actual child doing it. This is kind of an enclosed room. This is an open room version. So they tolerate it pretty well, but you sometimes have to do 3 rounds of it for them to kind of figure out how to do it. But it helps to see if you have the stiffer lungs or if you're not exchanging oxygen. These are other things that we're going to look for when we talk and ask you and then do some studies, is to see the GI can be extensive: dry mouth, reflux, mobility issues like getting down from the esophagus to the stomach. So all of these things, we kind of ask a lot of questions, but then we also do some imaging. Like this is an example of a small bowel follow through after a study where they swallow dye, and you can see this patient is an adult but has a very dilated esophagus, so that's a scleroderma change that can happen in kids too. What we usually start off with kids is have them do a swallow study with a speech pathologist, so they eat little amounts of food that have a little bit of like radio dye in it, and just see, are they having trouble with liquids, with kind of mushy foods, with solid foods, and then follow that up by doing this, like a fluoroscopy, where the radiologist is taking x-rays and seeing where, if the gut has any dilation or strictures along the way. If the patient is taking a long time to like empty their stomach, they can only eat small amounts of food and they're getting really full, then sometimes we'll do what's called a gastric emptying study that is a nuclear tracer and just sees how long that transit happens. And sometimes if the patient's having a lot of like diarrhea and constipation and weight loss and their body mass index is going down, we might suspect that there's a bacterial overgrowth issue from the intestines not going, kind of moving through the right way. So sometimes they do a hydrogen breath test too. This is the percentages in that CARA cohort I mentioned. About 42% had GI issues, and this is the breakdown. So most had either dysmotility, so just not plumbing through the system the correct way, or GERD, gastroesophageal reflux, followed by dysphagia, like feeling that food was getting stuck when they swallowed. Musculoskeletal symptoms in the juvenile systemic, as I mentioned, is more common than the adult, so more arthritis, myositis, etc. So cardiac manifestations also happen in pediatric scleroderma, less common, but it does cause a variety of things like arrhythmias, congestive heart failure, and it is, as far as like mortality, thinking about that, that is one of the major causes in the older cohorts. It does have a certain antibody that we look for, but we do an EKG, a Holter monitor, et cetera. Renal, as I mentioned, that scleroderma renal crisis is way less common in kids, so that's why the kidney has a thumbs up. Less than 5% of the kids versus 15 to 20% of the adults. And then management of systemic scleroderma, similar to localized, as I mentioned, but really push that occupational physical therapy for their nods, obviously some protective measures, heat packs, gloves, mittens. The vasodilators are the extra medicines I didn't mention. That would be topical, patches, oral medications. Again, I'm going to leave that to Joanna to go over those meds in detail. And the systemic medications are very similar to the localized I mentioned. The extra also in systemic would be the GI medicines like antacids, promotility agents, rotating antibiotics if needed, and then just supportive measures, raising the bed, eating small meals, avoiding really acidic foods, things that would bother gastroesophageal reflux. And I just wanted to end on the kids get scleroderma too, as you guys know. That's what this talk was kind of highlighting, and that we have a lot of resources here through the Scleroderma Foundation. Mary Beth is right here in the audience, and she really helped organize with Suzanne Lee, myself, and Ann Stevens, a really fun first time Kids Get Scleroderma 2 only conference in Hackensack, New Jersey this past Halloween, and this was us having fun with all the kids, and there's one coming up in Colorado this October as well. So just as far as, I just wanted to announce that as far as networking for the families, it's great to just be a kid. We had a really good time with the, costume party the night before and networking, so that's beyond the clinicians, and obviously, hopefully, we're here to help you, but then there's also support through the Scleroderma Foundation and the families you'll meet and the children interacting as well. So that is the end, and then I'll open it up for questions. I think we have like 5 minutes for questions, sorry.
Check, check. If you have a question, if you can raise your hand, I'll bring you the mic so we can hear you on the video. We won't see you, but we'll hear you. So, questions?
Yeah.
Our daughter Landry, she's 11, and she's been on methotrexate for almost 2 years. She seems to be pretty stable with the medication, we think. Like, that was one of my questions, like, how do you know? Because she still has some of the facial tightening and lip thinning. And when we've gone to other classes before, they say that that's almost like a separate type of sign. Like, it's not really a sign that the methotrexate's not working. Mm-hmm. Is that true? Is that, like, completely separate? Like, just it's going to happen no matter what, and so we shouldn't use that as an indicator that maybe the methotrexate's not working?
Yeah, so I think the question is more systemic scleroderma, correct?
Yes, yes.
So localized versus systemic is a little bit different in the monitoring. So some of the ultrasound and the MRI I was mentioning was more for the linear or localized scleroderma. For systemic scleroderma, it is a little bit harder because there are more fibrotic or atrophic changes that will occur, as you mentioned, sometimes regardless of the therapy. So that is a little bit harder to monitor. In general, the skin thickness progression rate is helpful to monitor. So if your child was getting more skin thickness areas, like, hey, her chest wall wasn't thick or her arm wasn't thick and now it's getting thick, that would be active disease or something new. Or if the thickness was regressing, if they had thickness in different areas and now there's less areas, that's a good sign. So that's what we use a little bit more to monitor systemic scleroderma, is that skin score, like the total skin score. Because yes, some of those changes are going to happen regardless of therapy. But in general, I think most pediatric rheumatologists across the board will treat with, methotrexate, Celsep, these agents for a fair number of years. So most will not just treat 1 or 2 years and stop. Many will kind of continue to treat because the immune system kind of needs to kind of remember to kind of stay neutral. And we can talk individual patients later, but that's in general, yes, some of the signs kind of occur regardless of therapy, but as long as the new things aren't happening or new areas of the skin aren't involved, that's something else that we're looking for as well.
Can you tell me, like, the thickness you mentioned on the fingers, the puffiness, like she's at that phase, and one of the moms had a question too, like, how long before it starts curving, and like how much time?
Yeah, it's individial patient, and it
so
changes.
There isn't
the
like,
diffuse.
around 5 years,
Yeah.
that's when you start noticing.
I can say just from my patient experience, it is variable. I've had patients that have had sclerodactyly for years. They've seen different clinicians around the nation. They've come to me, and then we've had changes within a few years on certain medicines and it kind of going back to normal, but a lot of times the fingers won't go all the way back to their prior scleroderma fingers, but, that puffiness will go down. But typically, it is within a few years of treatment, using systemic therapy.
Okay.
But then they will have some remaining kind of like, puffiness of their fingers.
Okay, thanks.
Mm-hmm.
Starting up here.
You got a double.
Sorry.
When you talked about the limited or the linear scleroderma, you said that usually you don't see overlap or GI issues or any of this. What in your studies have you found? I mean, are you not finding any case? Because we are in the middle of an overlap with limited or linear or whatever you want to call it, being put into an overlap into a systemic side. Right now, we have, a positive RMP with a mixed connective, but we're still rattling out the sides now. And I just wonder how much in your studies that you're seeing, or are you guys, is there anybody studying this right now? Because I'm reaching out to some other families and seeing that some of these other families are having some of the same situations that I'm going through right now that are on not the systemic side.
Yeah, so I would say of the localized scleroderma, there are, that percentage that do have certain extracutaneous manifestations. So I can think of on top of my fingers, like 5 or so patients that have true systemic scleroderma GI issues that have linear, or localized scleroderma. But it's kind of like they don't have the antibodies or they don't have Raynaud's or the skin thickening or anything else that goes along with systemic. So I still consider them extracutaneous manifestations of localized because it's kind of just the GI issues that are systemic with the localized. They don't have antibodies, but you're saying, hey, someone that has RMP, and if they had Raynaud's or other things, sure, then they probably are like a kind of overlap of connective tissue disease. Or I would say in my cohort, the National Registry of Childhood Onset Scleroderma, out of like 450 localized scleroderma, there's less than 5% of patients that would have that. So it exists, but it's very
Right now
uncommon.
we have, a positive RMP, but we don't have Raynaud's. We have a lot of the GI issues. We have, our mobility of our stomach right now, he's losing. So many things that are going with it, but I read so much that everybody says that they can't be crossed or they're not crossed, or I've heard speakers talk about it, so that's where I'm,
Yeah, so that would not meet the criteria of systemic. So it still is like maybe a mixed or undefined and undifferentiated connective tissue disease, but you still would treat the organ manifestations as you do in systemic scleroderma. You treat each organ manifestation. So you would treat his GI disease as you would treat a systemic scleroderma GI disease. You just treat the organ manifestation as it comes. So one is just a semantics thing, but 2 is the treatment. Sure, treat the gut as systemic scleroderma gut. That's not an issue.